Welcome to Roadmap to Residency. Hello everyone, I am Abhiraj. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So this patient most likely suffers from which of the following conditions? So straightforward question asking us about the diagnosis. Now let's dive into what the patient is all about. A 28-year-old man with vague abdominal pain, low-grade fever, and diarrhea is treated with antibiotics without significant improvement in his symptoms. Several weeks after symptom onset, the patient develops a skin lesion over the abdomen. His temperature is 100 degrees Fahrenheit, blood pressure is 120 upon 70, and pulse is 88. On physical examination, the abdomen is mildly distended and tender to palpation. Bowel contents appear to be draining to the surface of the skin in the right lower abdominal quadrant. This patient most likely suffers from which of the following conditions. Now here you can see that patient is having abdominal pain, fever, and diarrhea, which is not getting relieved with antibiotics. Plus, the patient has developed extraintestinal manifestations such as skin lesion, and the patient is also having fistula or the draining sinuses from where the abdominal content is or the bowel content is being drained out through the surface of the skin. So the patient has which of the condition? Acute appendicitis, Crohn's disease, mesenteric adenitis, pseudomembranous colitis, or ulcerative colitis. Please pause the video and think what is the answer. So Crohn's disease and ulcerative colitis are collectively referred to as inflammatory bowel disease, and they may have similar clinical manifestations, but they also have key distinguishing features. Crohn's disease typically presents with prolonged diarrhea and abdominal pain, and diarrhea can be bloody if the colon is involved. Constitutional symptoms like low-grade fever, malabsorption, and weight loss can also be seen. Transmural inflammation of the bowel wall may result in the formation of fistulas and fibrotic strictures causing bowel obstruction. Fistulas can form between two adjacent loops of bowel, that is enteroenteric fistula, between the bowel and the another organ, example bladder and vagina, or between the bowel and the skin of the abdominal wall, that is enterocutaneous fistula. Our patient is suffering from enterocutaneous fistula. Perianal fistula and abscesses are also often seen in case of Crohn's disease. So this patient is the diagnosis have become Crohn's disease. Now, what typically happens in Crohn's disease? As you can see in Crohn's disease, there can be formation of transmural inflammation, abscess, enteroenteric fistula, oval stool appearance, fibrotic stricture. Now, general characteristics, Crohn's disease is a chronic transmural inflammatory disease that can affect any part of the GI tract from mouth to anus, but most commonly involves the small bowel, that is the terminal ileum. Here you can see in this picture, the effects are generally shown in the terminal ileum, and the patient is having transmural inflammation, that is inflammation of the whole of the layers of the GI tract. Now, the distribution, there are three major patterns of the disease. 40% of the patients of the disease having in the terminal ileum and the cecum. 30% have disease confined to the small intestine. 25% have the disease confined to the colon, and when there is colon involvement, then the patient will be having blood diarrhea. And rarely other parts of the GIT like the stomach, mouth, and esophagus can be involved. For the pathology part, the terminal ileum is the hallmark location, but other sites may also be involved, as we have discussed in the above. The skip lesions, that is the discontinuous involvement, that is means that there is lesion at one site, and again there is a normal mucosa, and again there is the lesion at the other site, that is called the skip lesions. Or fistula, liminal strictures, non-caseating granulomas, transmural thickening and inflammation, that is the full thickness wall involvement, resulting in the narrowing of the lumen, and mesenteric fat creeping onto the antimesenteric border of the small bowel can be seen in Crohn's disease. The clinical features may be diarrhea, usually without blood only when the colon is involved, malabsorption and weight loss, abdominal pain, fever, some extraintestinal manifestations like uveitis, arthritis, ankylosing spondylitis, erythema nodosum, pyoderma gangrenosum, aphthous ulcer, cholelithiasis, and nephrolithiasis. We will have a separate video on the complications or the extraintestinal manifestations of the inflammatory bowel disease. We will discuss in detail there. Diagnosis: endoscopy with biopsy. Typical findings are aphthous ulcers, oval stone appearance, pseudopolyps, or patchy or skip lesions. The diagnosis is done by the barium enema or the upper GI with small bowel follow through. Complications of the Crohn's disease include the fistula between the colon and other segments of the intestine, or the bladder, or in the skin. There can be anorectal fissures, abscess, or perianal fistulas. There may be edema and spasm of the bowel with intermittent signs of obstruction, or small bowel obstruction can be there. There can be malignancy, increased risk of Crohn and small bowel tumors, malabsorption of vitamin B12 and bile acids, both occur in the terminal ileum. So if the terminal ileum is affected, then there will be vitamin B12 deficiency. Cholelithiasis may occur secondary to the decreased bile acid absorption. The patient may be also having nephrolithiasis and aphthous ulcer and toxic megacolon. So the complications of Crohn's disease are very, very important, because the questions will typically ask you about what the patient is at increased risk of. Generally, they ask you about the malabsorption of vitamin B12 and toxic megacolon. Although this is the less common complication of the Crohn's disease, uh, generally asked in the ulcerative colitis part, but also this can be a potential question in your USMLE step 1, because everybody knows about the fistula and anorectal abscess and all happening in the Crohn's disease, but there may be some who will miss the information that the malabsorption of vitamin B12 can also happen in case of terminal ileum. And by framing the question like this, they have also touched the hematology part. So questions like this will be mostly in your step 1 examination. So in this slide, the most important point that you always need to remember is the malabsorption and toxic megacolon. The treatment of the Crohn's disease, there is medical and surgical treatment. So the medical treatment is systemic corticosteroids and budesonide. You need to attempt to taper when the symptoms are clinically improved, and if we are unable to taper, then we need to consider the immunosuppressant like TNF inhibitor or methotrexate in some patients. The surgery is reserved for complication of Crohn's disease or for those who have persistent symptoms despite best medical management. It involves the segmental resection of the involved bowel. The disease recurrence after surgery is very, very high. And the incidence of surgery include the indications of surgery is generally due to the small bowel obstruction, or whenever there is a fistula or there is perforation or abscess. The nutritional supplementation and support is needed, as you all know that the patient is having vitamin B12 deficiency, so you need to supplement the patient with some nutritional supplementations. Now talking about the ulcerative colitis, it is a chronic relapsing ulcerative inflammatory disease of undetermined etiology that starts in the rectum and extends into the colon for a variable distance. So it starts from the rectum and extends towards the colon. And now you know from the Crohn's disease that whenever the colon is involved, then the diarrhea will be bloody type. So it is the most common type of inflammatory bowel disease. The ulcerations are in continuity. There are no escape lesions like the Crohn's disease. There is abnormalities in the humoral and cellular adaptive immunity in this patient. Generally, there is decreased risk in current smokers and increased risk for excess smokers, and the patient are at increased risk if the patient is suffering from autoimmune disease. Talking about the clinical features, the patient will be having bloody diarrhea, abdominal pain, bowel movements are frequent but small. There will be tenesmus and some extraintestinal manifestations like jaundice and uveitis. So the type of diarrhea, bloody or non-bloody, is a very important clue in diagnosing the Crohn's or ulcerative colitis. The diagnosis is stool cultures for the Clostridium difficile, or you need to look for the fecal leukocytes. WBCs can appear in the ulcerative colitis. Colonoscopy is used to assess the extent of the disease and the presence of any complications. So what complications? The complications are generally the iron deficiency anemia, because there is blood loss, hemorrhage, electrolyte disturbance, and dehydration secondary to the diarrhea. Strictures which are benign or malignant. Colon cancer, there is increased risk. Sclerosing cholangitis, cholangiocarcinoma, toxic megacolon. Now, this is very, very important complication for the ulcerative colitis and is frequently tested in the examination. The patient can also suffer from the psychosocial issues. The treatment, the patient, we generally prefer sulfasalazine, which is the topical application as a suppository as the mainstay of treatment. It is preferred over topical steroids and can be used as maintenance therapy. Also, some oral glucocorticoids are used when the patients fail to respond to the topical and oral 5-amino salicylate treatment. If adequate clinical exposure is achieved, attempts to taper off of the corticosteroids or the glucocorticoids is done. Also, in some cases, we can use the TNF inhibitors and 6-mercaptopurine if the patient is not responding to the corticosteroids, or for if the patient has a very severe disease. Now, this is a very brief difference about the Crohn's disease and the ulcerative colitis. We will have a detailed discussion about the differences between the Crohn's and UC in another video. But for now, to summarize everything that I have told you, so involvement in Crohn's disease is anywhere from mouth to anus, but from ulcerative colitis is from rectum up to the colon. The patient have non-caseating granulomas, but in ulcerative colitis, the patient do not have granulomas. Now, this histological feature is also very important in case of the USMLE style questions. In gross findings, you can see that in Crohn's disease, the patient have transmural inflammation, linear mucosal ulcerations, cobal stoning, or creeping fat. But in case of ulcerative colitis, there is mucosal and submucosal inflammation. There is no transmural inflammation, and there can be pseudopolyp formation. Clinical manifestations include abdominal pain and watery diarrhea. There will be bloody diarrhea in case of ulcerative colitis. Intestinal complications will be fistula or abscess, but the important complication of ulcerative colitis is toxic megacolon. Thank you for watching. Keep studying hard.